So one last question on this case before we go on to the last case, and that would be, so suppose it's now a year later, and this lady now has a 1 centimeter tumor in her breast. Her bone disease remains relatively stable. How do people feel about local management of the breast itself in the setting of oligometastatic disease that's stable?
I can start.
Go ahead, Edith.
In the absence of prospective randomized data, but using experience, I would not hesitate asking the surgeon to evaluate the patient for removal of the lesion and the breast. And one of the reasons for that is that I've seen this happen in multiple occasions where the patients do very well and the tumor grows exactly where it originally was. So based on that, I would make that recommendation.
Yeah, you know, obviously we don't have the test to tell us who's going to do well for a really long term, which would make local control surgery more relevant as opposed to the patient who you're going to take to the OR who's going to develop liver metastasis 6 months later and you're going to say, why did I do that? So the best test, I think, is the test of time. And for me, about 1.5 to 2 years is when I start to think about the idea of local control surgery.
Does that sound reasonable? Yeah, everybody's.
Although one of the issues is, right, that which is, you know, I don't know how to think about, is the idea that if you have a bad cancer and you leave the tumor in and you control it for a while, that then it reseeds from that primary tumor, whereas the people who have really slow-growing disease, it doesn't matter what you do.
I've heard of that.
Yeah, I know. There's someone in your institution a little bit older. Do you believe, honestly, I mean, do you believe in the reseeding theory? I'm not necessarily sure I'm a believer in that.
I love hypotheses and I love data even more. And at this ASCO meeting, Terry King is going to present some data from a TBCRC study looking at oncotype testing of ER-positive, HER2-negative patients with metastatic disease, simply looking at it as a prognostic tool, not as a tool to predict chemotherapy benefits. So we would like to have that crystal ball for these patients.
But it may be, I guess I just want to point out is that it may be the higher risk patients who benefit. We don't know who benefits from the surgery from the primary tumor. It could be the high risk patients. It could be that those patients who do really well, that it doesn't matter what you do with their primary tumor.
I think if we had data from how the people who have the primary tumor intact die, how do they die? Do they die from local extension, like from a pleural effusion or pericardial effusion, or do they die from distant mets to the liver and brain mets? How do they die? Because if they die from the mets distant, then you could argue, well, I guess if you don't believe in reseeding, okay, I'm not sure I necessarily believe in reseeding, but if you argue they're dying because they have carcinoma and cuirass or something else like that, you know, I'm not sure.
Well, that's why it's the really aggressive, sort of locally inflammatory disease that if you get a response and you could do surgery really fast, maybe you could somehow protect them from the nasty things that happen, what I call Job's disease, you know, when they have horrible disease on their chest wall. But we just don't know. And actually, Terry King's study with this Translational Breast Cancer Research Consortium is going to help us a lot because it's a multi-center study where we all enrolled patients within some number of months of their metastatic diagnosis. She has their circulating tumor cells that were done, the tumor tissue for the oncotype, and we'll get the natural history of these patients too.